We are presenting the implementation of a virtual social needs help desk in the emergency department during the COVID-19 epidemic. My name is Ramya Kandeli, and I'm an undergrad at Stanford.
My name is Emily Shear, and I'm a fourth-year medical student at Stanford.
My name is Cesar Armas, and I am also an undergraduate senior at Stanford University.
Stanford Health Advocacy and Research in the ED, otherwise referred to as SHARED, has run the ED Help Desk at Stanford, founded in 2009 by intending to address the social needs of the patient population. Stanford, as a suburban ED in an academic hospital, sees 70,000 patients a year. The help desk functions to acknowledge the role of the emergency department as a social safety net for these patients and assist in connecting patients with common social and legal needs to community resources. We do this with a team of primarily undergraduate volunteers, and we're run by student leaders as well as Dr. Wong, and assisted by other incredible staff and students in the Department of Emergency Medicine. Volunteers that carry out the screening join the program by applying in the fall, commit to at least 3 quarters of screening that can occur anytime during their undergraduate career. We have many that screen for longer. Recruited students take a course in the winter addressing social determinism in the Bay Area, a key for contextualizing the resources and needs volunteers will face in the emergency department. During this time, students can also shadow current volunteers to understand the role from an inside perspective. After the course, students begin screening after completing HIPAA and city compliance training, as well as being trained on appropriate motivational and empathetic interviewing techniques, and how to use the platforms we use for finding resources and following up with patients. We had several resources at our disposal to run the help desk. As far as resources for screening, we have a brief screener form, a resource database that we can use for referrals, a follow-up database, and a protocol for following up with patients regularly, and protocols for emergencies and elevating certain patient cases to social work for cases we can't handle. Finally, we have collaborations with social work, nurses, and community partners in order to close the loop for the needs of our patients. As far as physical resources, we have 2 iPads for screening in the ED, a phone for following up with patients, and a file cabinet and stuff storage in the emergency department as needed. As far as protocol, students would take bi-weekly 2-hour shifts. They would start their shifts by asking ED staff for patients eligible for screening, which is especially important for us, so we operate within what we can provide. Once patients are identified, we administer a brief screen form and ask patients if they need help or resources in general areas. If that initial screen is positive, we begin intake into our system, conduct a more in-depth screening, and find resources and referrals for patients according to their needs. Once finished, we follow up with the patients until their needs are met, typically every 2 weeks until the need is resolved.
At the onset of the pandemic, in-person screening was immediately halted. Considering the worsening financial times, as well as the burden of having to shelter in place, we believe the need for a social screening platform had significantly increased. With volunteers no longer being allowed into the Stanford Emergency Department, we had to adapt our services to fit a telemedicine-type platform. Seeing that every patient room has an iPad that can be called, we envisioned that virtual screening would be effective. Since COVID-19 has changed the way many community resources are operating, we first had to contact these organizations to ensure that patients could continue to receive assistance, as well as to build relationships with community partners to encourage further impact. Our second objective was to find a way to be able to connect with doctors in a manner that was fast and unobtrusive to their work to identify patients eligible for screening. Next, we needed to find a way to deliver resources to patients, as well as a way to follow up with patients to ensure resource effectiveness. Finally, we had to train our volunteers in empathetic telemedicine methods while constantly checking in every week to work through any problems in the screening process as they arise. With the support of our IT team, as well as the social service delivery platform Alberta, we developed a screening tool capable of delivering COVID time available resources through virtual channels such as text message and email. This screener takes patients through questions that examine whether they require any of the social needs we can meet. Following this, we then created a way to connect to patients using the iPads that were placed in every patient room in Stanford Hospital's emergency department via Stanford's VPN and Zoom to ensure security. Since physicians are often hard to reach during their shifts, we decided that using already available channels of communication would be most effective. As a result, volunteers are able to connect with physicians via text message through Volt, an instant messaging application used at Stanford Hospital. Finally, we reached out to local community leaders to inquire about the availability of their services, as well as to invite them to speak at our companion course, EMID 125. The screening process begins with volunteers using Volt to ask physicians which patient rooms they would be allowed to screen. Once permission is received, volunteers call into patient rooms to establish contact with iPads located in such rooms. Once contact is established, volunteers use a personalized screener to assess patient needs. If a patient does have specific needs, they are logged and given resources through an email or text message that can be sent directly from our screening platform. 2 weeks after the delivery of these resources, volunteers can then use Doximity to call the respective patients to inquire about their progress in accessing the provided resources, as well as any further assistance that can be provided.
Our lessons learned were, first and foremost, that virtual social needs screening is possible and, in our limited experience so far, is acceptable to patients. This is important because it means other institutions may also replicate our efforts and produce virtual screening programs in their EDs. However, our success was heavily predicated on the existence of iPads in each patient room in our ED, which have served as general tools of communication during COVID in our ED as a way to limit exposure. Considering the launch of the program, we also learned several important lessons. First, troubleshooting our new process was time-consuming but critical. Prior to rollout, we trialed our new system on each other, on ED attendings, and on ED social workers to catch and fix as many technical bugs as possible before launch. Collaboration with ED attendings and social workers was also key in identifying patients who were good candidates for screening. A key part of this process was ensuring undergraduate volunteers knew when a patient's social needs were beyond their level of screening and required a formal social work intervention. Next, we found empathetic telemedicine training to be a useful adjunct for our volunteers, as telecommunication requires different skills in forming therapeutic alliances with patients. Fourth, having a solid follow-up process, including new ways to contact patients, was critical in ensuring our patients were able to actually connect with our referred resources. And finally, more research is needed, both into how efficient virtual screening is compared to in-person screening, but also as to the acceptability of each form of screening to both patients and staff in qualitative studies.
Good morning. I'm Dr. Jacqueline Ward Gaines from the University of Colorado and Denver Health Emergency Medicine Residency. This morning, I'll be presenting our oral abstract. It's titled Underrepresented in Medicine Scholars Develop a Diversity, Equity, and Inclusion Curriculum via a Virtual Externship. My authors are Christy Ingerhofer, who is a Diversity, Equity, and Inclusion Professional at the University of Colorado School of Medicine and Denver Health Residency. Dr. Gannon Sungar, who is the Associate Residency Program Director, and Dr. Taylor McCormick, who is Assistant Professor and has a Master's in Health Policy and Management Research. Traditionally, the Denver Health Emergency Medicine Residency has offered a clerkship for underrepresented minorities in medicine. The program focuses on a clinical and community service-based rotation. It's awarded to approximately 10 scholars per year. Last year in 2020, as we awarded our 10 scholars, COVID hit, and all in-person student rotations were canceled. Just like every other program across the country, we were extremely devastated. But that gave us a light bulb moment. How do we put our residency's mission first and still have the externship? So at this time, we decided to change it to a virtual format. And as the top mission was developing a diversity, equity, and inclusion curriculum, who better than to have input than URMs who are soon to be residents? We start developing our objectives. Again, the main one, advancing our recruitment efforts by engaging in a clerkship, be it virtual, and providing scholars some training. And so we started training them in DI, curriculum design, and research. Other programs across the country had started doing virtual rotations with things that are adaptable to Zoom, such as EKG, ultrasound. but we wanted to give them some training in these specific areas, and that they have a project at the end. They developed a comprehensive evidence-based 2-year DEI curriculum. So first, I think we all need to say thanks to COVID for Zoom. How many Zoom calls have we sat in over the past year? Thanks, COVID, for Zoom. That is the main way we did this, through Zoom. 13 weeks of Zoom. We did it with teaching them didactics. We also let them provide feedback on a needs assessment tool per the Kern model that we had already established. They learned how to interpret the data from the needs assessment. They worked with curriculum planning and building, mentorship, also developed scholarship through manuscript writing. The schedule looked as such: pretty intense with reading assignments weekly, individual meetings with mentors, and of course, the Zoom didactic classes. Well, we did it. 6 of the 10 awardees chose to participate in our virtual clerkship. Some were extremely excited because they had a series of elective rotations canceled. And so this 13-week span worked out really well in their favor. They presented at the end of the rotation some of their facilitator guides and slide decks. The scholars also received mentorship, but the mentorship this year was actually focused a lot on the 2020 emergency medicine residency application and interview process with the ambiguity of COVID. Here's an example of some of the focused curricular development we performed. Using the TAC model and Peterson's, we had objectives from awareness, attitude, knowledge, and skills. And as you can see, they used a variety of modalities such as case-based, lecture, simulation, and incorporated those learning objectives into section blocks and interesting ways to deliver that content into a residency typical conference day. In summary, the externs engaged through mentorship and creating this 10-hour evidence-based curricular DEI training. They actually left with some degree of expertise in cultural responsiveness, pedagogy, scholarship experience, and mentorship. Now, I know you didn't think we were going to finish this without a COVID molecule, but there are some limitations to everything. So, of course, these externs didn't have any clinical experience. And full disclosure, it wasn't enough time to build an entire curriculum. And with not having the clinical experience, we were able to actually see them finish a scholarly project, which I think tells a lot about an applicant or soon to be applicant. So when life gives you lemons, make lemonades, or when COVID comes, make virtual Zoom classes. Thank you very much for listening to my oral abstract.
Hello, I'm Angelo Cruz. I'm one of the chief residents at the University of Kentucky's EM residency program. I'm going to briefly speak with you about a program developed by CORD's Advising Students Committee in Emergency Medicine to help advise medical students who are considered orphan applicants. I have no disclosures to report. So before I get into the program, I just want to take a minute to talk about CORD's Advising Students Committee in Emergency Medicine, or ASCEM. So ASCEM, which was formerly called the Student Advising Task Force, was formed in 2013 in response to this perceived crisis in the emergency medicine match. So 2012 was the year where there were no unmatched positions within emergency medicine. And so then the over-applying phenomenon started becoming extremely apparent. Applicants were responding to the perceived increased competitiveness by submitting more applications. So ASCEM hypothesized that one of the big factors driving the application behavior was a lack of consistent, high quality, as well as easily accessible advice for advisors and students applying to emergency medicine residency. ASCEM strive to create and disseminate resources designed to guide the EM-bound student as well as their advisors to be able to apply, smarter and not harder. So ASCEM began as a small task force, and then over 6 years has grown into a large committee with 160 active members working in teams comprised of medical students, residents, clerkship directors, program directors, medical school deans, as well as others who are involved in medical student advising. So ASCEM creates and disseminates both evidence-based and consensus-based resources in response to the needs of both EM-bound students as well as their advisors to address each step in choosing a career in EM from preclinical years through the residency application process itself. So multiple teams exist within ASCEM. And so the team distance advising here exists to connect orphan medical schools and students with resources and advising. So what exactly is an orphan school as well as orphan applicant? Obviously, this is important. So the orphan schools are any medical school which is not associated with an emergency medicine residency program. And then the orphan applicant is the medical student applying from one of these schools to emergency medicine. So orphan applicants were identified by ASCEM as a population needing extra, unique advising recommendations. These students are at a significant disadvantage because, they're usually lacking a personalized advising from a faculty member that's directly involved in the, residency application process. Emergency medicine and the match process itself have undergone significant changes in the past few years, and, especially with COVID-19. So these students may not have access to the most up-to-date recommendations, especially considering, they've been changing so rapidly. So ASCEM initially produced an electronic advising guide for orphan medical students, which is housed on our blog and on the CORD ASCEM website. But there still existed a need for real-time advising for these students. So COVID-19 obviously dramatically exacerbated the difficulties that the orphan applicants were having while they were seeking out mentorship and applying to EM residency. And while the need for a formal advising program had previously been recognized, the past year made implementing one imperative. So, this program was created to provide a reliable, evidence-based advising, to attempt to level the playing field for these orphan applicants who previously may have been significantly disadvantaged during the application season just due to the lack of advising. So the purpose of the distance advising program itself was twofold. So initially, or first off, to identify the orphan medical schools and connect them with at least one faculty member from an academic emergency medicine program by geographic location. And then also to provide this robust evidence-based advising to the applicants, and to do so in a sustainable way such that we could continue to do this through many application cycles. So to begin the program, 80 medical schools were identified as orphan medical schools. So each school was contacted, usually through the Dean of Student Affairs, to gauge their interests. And then all the members of ASCEM were polled for their interest to act as advisors. 50 academic faculty members, including program directors, clerkship directors, assistant program directors volunteered. And so those orphan schools were then matched with those ASCEM members by geographic location. And then the students were then connected with the advisors via email. And then the number of students assigned to each advisor varied by school size and need. So the distance advising program ultimately connected students who previously had no formal advising or mentoring with academic emergency medicine faculty. And so we hope that in this time of high stress and uncertainty, that this provided some support for the students. And ultimately, we're aiming to provide those students with the most accurate and evidence-based advising, and do so in a way that's sustainable through multiple application cycles. And so in the future, data will be collected on the outcomes for these students, and then we can further characterize the effectiveness of this program, and then hope to grow the number of students that are advised. So if you have any questions, I'm here with my APD, who happens to be the previous chair of ASCEM, and we're happy to take any questions. Otherwise, thank you for your time.
Hi, my name is Amanda Deutsch, and I will be presenting our oral innovation, PennEM Fit Tested, Moving Together Towards Wellness During the Surge, an innovative wellness initiative. This was a wellness challenge that took place at the University of Pennsylvania. It is estimated that 46 to 60% of medical trainees experience symptoms of burnout. We know that physicians are at a much higher risk of depression, burnout, and suicide compared to the general population. Unfortunately, when matched age-related to their own peers, physicians continue to have a higher risk of suicide as well. We also know that emergency medicine is a particularly high-risk specialty for burnout. EM consistently ranks amongst the specialties of highest rates of burnout. In the 2021 Medscape National Physician Burnout and Suicide Report that's already come out and been surveyed of physicians this year, EM once again is ranked top 10 in specialties of highest rates of burnout. The only fortunate news is this year, only 42% of physicians altogether ranked as being burned out. We believed the COVID-19 pandemic was going to further exacerbate those factors that contribute to burnout. It is also known that participating in at least 150 minutes of activity per week can lead to many health benefits, not just physical benefits. This regular physical activity can also provide psychological and social benefits. In the setting of this, we decided to implement a residency physical activity challenge during the first COVID-19 surge. We were hopeful that we could maybe lead to less burnout and lead to more wellness by doing this. Our objectives of our challenge was to encourage regular physical activity, increase a sense of community during the pandemic, and improve overall wellness for our residents. We designed a 4-week wellness quality improvement initiative. This was opt-in participation for our residents in the emergency medicine program, which consisted of 46 residents. We asked those residents to create and download the Strava app, which was a free app that they could join, to then join the club in Strava of PennEM Fit Tested that we had created. To get credit for the activities, they would then have to post their activities that they had done in Strava. Points were awarded for daily physical activity, but this had to at least equal up to 30 minutes of activity, which did not have to be consecutive, but had to be cumulative throughout the day. And this kind of activity could be anything. It could be walking, hiking, biking, going on a jog, swimming, climbing, anything residents wanted, including choosing to not use the Uber or bus to get to their shift, but going on a walk. We then, if they had done 5 days of activity per the week, they were eligible for a weekly prize, and overall prizes were given to those residents that had scored the most points by doing the most activity. Additional prizes were awarded for creative pictures, fun activity titles that were posted into the PennEM Fit Tested Club on Strava. After this, we surveyed residents at the end of the challenge to see what the overall impact had actually been. Altogether, 28 residents opted to participate in the challenge of our 46, and our response rate to the survey was 89.3%. 76% of residents identified the challenge as helping them be more physically active than they would have if not participating. 92% stated the challenge improved their overall wellness. And again, 92% said that the challenge actually fostered a personal sense of community during the pandemic. It's important to note that Philadelphia had a stay-at-home order that had went into place on March 23rd, of 2020, and our challenge took place from April 13th, 2020 to May 10th, 2020. Overall, in the world, the pandemic had already spread to 198 countries at the first week of our challenge by April 18th, and 2.4 million confirmed cases were already at that point in time, and 150,000 deaths globally. Our study was limited by being opt-in, which could of course lead to recruitment bias and be potentially not applicable to all residents. We only looked at a single university residency program. And as we all know, non-respondents may represent the more negative attitudes. What we can conclude from our challenge is that physical activity challenges can promote a sense of community and positively impact the overall wellness of residents. Similar challenges could easily be implemented at other programs. And although it's not a novel wellness concept to do a physical activity, the importance and ability to create a virtual club and foster community, especially during this grossly isolating time of the pandemic, cannot be overlooked. Lastly, I would like to thank my co-residents that participated and went along with this, as well as thank Rabbit for supporting the initiative and our residents and supplying the awards we were able to give them. Thank you and have a great day.